Hello, today we'll look at the symptoms of pneumonia. What does pneumonia mean? Pneumonia means infection. Infection. Okay, infection. And infection will lead to fever. Fever. And also cough. So here I will draw a thermometer, and this will show more than 38 degrees Celsius. Cough, here I draw a patient who is coughing up. If it's mucopurulent, which means it's thick, then it's usually a bacterial one. So bacterial. If it's mucopurulent, bacterial, and then it's typical. If it's more watery, then it's atypical. So that's the way you can distinguish between the different types of pneumonia, for example. So if it's more bacterial, then you give antibiotics. If it's atypical, it's maybe due to a virus, then antibiotics will not help. And atypical is more watery, mucopurulent, and bacterial is more mucopurulent. So it's thicker, it's more yellowish, and so on. So it's more bacteria there. So if you remember only two things here, fever and cough, this should be enough. But always remember, symptoms are not enough, because the gold standard or the most important test to make is chest x-ray. So x-ray. That's the most important thing you need to do. This has nothing to do with symptoms. Symptoms are only there for you to guide you in the right direction. So you will think of pneumonia now when you have a patient who has fever, cough, and I will tell some more symptoms. But remember these two symptoms. These are most important. And if X-ray then shows that it's pneumonia, then it is. If it does not, then it's probably not. Okay? Then you have to look for some other diseases that has fever or cough in it. If chest X-ray is not enough, then you do a CT scan. CT scan is more expensive, so you should not start with this. It's more accurate. CT is more accurate than chest X-ray, but the most important test is the chest X-ray. Why? It's cheap and it's more than enough. You don't need CT to diagnose patients. You just need an X-ray, and then you start with empiric therapy, which means we start with the broad spectrum of antibiotic. And it has been proven that chest work is more than enough. And therefore it's the diagnostic tool of choice. Good. Cough. If you draw a lung here, then you have to remember dyspnea. Dyspnea, which means difficulty breathing. Dyspnea. And then also I will draw a sign here indicating that it is very painful. So this is pleuritic chest pain. Pleuritic chest pain, dyspnea. So difficulty breathing, pleuritic chest pain. And the breathing rate is more than 24 per minute. And as we said always, symptoms can be there alone or in combination. So maybe a patient comes in with only cough and pleuritic chest pain. He does not have dyspnea, so no difficulty breathing, and he does not have fever. That's a case. Or another patient comes in with only fever, but nothing else. So remember, these combinations can be endless. Okay, there are millions of combinations. The most important thing is that you recognize one of them or more of them. Okay? So fever, cough, dyspnea, so difficulty breathing, pleuritic chest pain, a breathing rate of more than 24, and a heart rate of more than 100. So that's tachycardia. So if you have more breathings per minute than usual, because the usual is usually 15, and if you have more beats per minute of your heart, which is more than 100, then that can be a sign of pneumonia. What other things do we have? If we use our stethoscope, so if here I draw a stethoscope, and with this tool I can now listen to the lung, and I will hear crackles, and I will hear bronchial sound. And if you're curious about how this sounds, then go to YouTube, type it, and you will find some good samples of a stethoscope showing how, for example, bronchial sound will sound compared to the vesicular sound. So the vesicular sound is the normal one and bronchial is the abnormal one, okay? Then what can you do? You have, for example, your hands. You can use your hands, and if you put this part, the ulnar part, on the back of the patient, and then you call this tactile fremitus, if you ask the patient to say 99, 99, 99, and then you will hear the resonance, then you will feel the resonance in your hands, that it is different. Okay? So that's called tactile fremitus. Then what else? You have, for example, dullness. So if you percuss the patient, then you use your finger, this long finger, and then you percuss the back of the patient. And if you hear a dullness, for example, like this, did you hear? That was a dull sound. You didn't hear it so good as this one. Okay? So that's dullness at the part of pneumonia. And then you have something called egophony. Egophony. This means that if you ask the patient to say E, you will hear A. So the same again, I use my stethoscope, I listen to the lung and I ask the patient to tell E, and I will hear A instead. That's egophony. So these are all very, very cute and very interesting things that you can do with the patient and interesting symptoms. But as we said, X-ray, X-ray, X-ray. That's the most important thing. Forget all this. This is just a way for you to navigate, because in not every case of bacterial pneumonia will show a mucopurulent cough, meaning a thick cough. And not every case of atypical pneumonia will show a watery cough. But it has been seen that more of the mucopurulent cough is indicating bacterial and so on. So it's an indication. And the same goes with fever. If you, for example, want to compare pulmonary embolism, another lung disease, and pneumonia, then you look at fever, because there's not really a fever in pulmonary embolism, but in pneumonia it is. This is an infection. Okay? Good. And what do we need more? We have one or two things more that we can say. For example, if we have a patient here, he can also have chills. And then this is a patient who is having chills. Okay? So, and then also we can have patients with mental status. This is a beautiful brain. Okay, it doesn't look like a brain. I'm not so good at drawing. Let's see. Let's try this again. Okay, this will maybe look as a brain. I don't know. Very ugly brain, but you get the point. Mental status. Mentally, he is different. And also, what do we have left? I think we have, vomiting. Vomiting can be seen also. So if we have a patient here and he is vomiting and he has nausea and also diarrhea. Okay? So, let's conclude this. A patient comes in with fever. The thermometer shows more than 38 degrees. He's coughing. We look at the cough. Is it bacterial or atypical? If it's bacterial, then it's more thick and it's yellow and it's more ugly. If it's atypical, it's more watery-like. He complains of breathing dysfunction. So he has pain, for example, when he's breathing. He has a breathing pattern of more than 24 per minute. We hear his heart sounds is more than 100. We then listen to the lung and we hear a bronchial sound and crackles. When we do the physical examination, we check the tactile fremitus. We tell the patient to say 99 and then we feel the resonance. We also percuss the patient and then we hear it's dull, and we tell the patient to say E while we listen to the lungs, and we will hear an A instead. We see that the patient is having chills. We see that the patient have mental changes, and that he had been having diarrhea, and he has nausea and vomiting in the last couple of days. So this is a typical pneumonia case. And as I said, you can combine any of these combinations. And the most important thing that we need to do is, once again, chest X-ray and start with empiric therapy, which means a broad spectrum antibiotic. Thank you very much for listening.